Welcome everybody to this week's happy hour. We're very pleased to, by popular demand, have Dr. Sandra Osswald hosting today's session. As many of you remember, Dr. Osswald is actually the chief of dermatology at the University of Texas Medical School in San Antonio, has been an academic dermatology for years, is boarded in internal medicine as well as dermatology and dermatopathology, and was in the military for 20 years, brings a vast experience and number of years with teaching both clinical dermatology and dermatopathology. And she's going to be addressing boils, bubbles, toils, and troubles, a wide variety of inflammatory disorders, which, as the name implies, do involve some blistering. And so before I turn the floor over to Sandra, I wanted to remind everybody that we're going to be doing a Dermpath core exam review on Saturday, February the 13th. The registration can be found on our website. If someone wants to post it in the chat room, that would be great. And the slide deck and questions should go out this week so that we can discuss them the following Saturday. The sessions will be recorded, so I realize it's a holiday weekend and some of you may not be able to attend, but they will be recorded and the discussion sessions and posted on YouTube. So without any further hesitation, I'll turn the floor over to Sandra. This is a pre-recorded session. And so if you have any questions, please send them to sagis@education.com, and either Dr. Osswald or I will be back in touch with you. And I'll jump back on at the end of the presentation and check the chat room then. So thank you very much.
Thank you, Tom, for inviting me and allowing me to speak again. I'm very excited about today's topic because today I called our session Bubbles, Bubbles, Toils and Trouble, because we're going to look at bubbles or blisters. And we're going to feature the process of acantholysis, which means the cells are coming apart literally. And we're going to see many benign conditions and go to some serious conditions. But these really are some of my favorite kind of slides. And so I hope you enjoy them well. And thank you also, Tom, for pulling such a wonderful slide set for me to talk about today. So we'll go ahead and get started. And the first slide is here. And you can see that it is a shaved biopsy from the trunk of proximal extremity. And already from this height, you can see that there is a subcorneal split. Here is acute vascular restrand corneum. So you can tell that this process has occurred quite quickly. And then you can see this quite robust inflammatory infiltrate in the subcorneal region. And when you look closer, you can see that this infiltrate is made up of, and let's get a little bit closer, a lot of kind of grungy material, but lymphocytes and neutrophils, right? Does everybody see that the infiltrate is filled or jam-packed with neutrophils? And when you have a subcorneal pustular dermatosis like this one, you might want to bring out your mnemonics to help you. Remember, mnemonics aren't meant to be all-inclusive. They're just a starting point to help you with thinking about differential diagnosis. And our residents use the mnemonic SMART PICS for this one. SMART PICS stands for, S is for Sneddon-Wilkinson, M for miliaria, A for AGEP, or acute generalized exanthematous pustulosis, or acropustulosis of infancy, Reiter's, tinea, impetigo, psoriasis, candida, and syphilis, right? So that is your SMART PICS differential. Now, when you look at this, you're looking for clues. And here you can see in some of the grunge, some purple clumps of bacteria. See that here? Here. And you can kind of scan across and see there seems to be some bacteria here, another clump over here, and over on this area. Now, sometimes these can be hard to see, and so you might want to do a special stain, but these clumps of bacteria are very representative of this entity, which is Bullous impetigo. And typically, this bacteria is going to be your Staph aureus bacteria, And because this bacteria can produce an exfoliative toxin, which is basically a serine protease, that is targeted in this case against desmoglein 1. Remember, desmoglein 1 is in the desmosomes, or those intracellular bridges. And when you attack those, and those bridges come apart, and you have acantholysis. Desmoglein 1 tends to be in the upper portion of the epidermis instead of the lower. And so you're going to see the most change in the upper epidermis. And let me show you what acantholysis looks like. Here is a really wonderful spot to look at. See these keratinocytes? Some of them have already come apart, and you can see them up here in the grunge. You see this? And then you could also see that some are barely hanging on by, 1 or 2 intracellular bridges, see here, but others are floating away. So this beautiful example of acantholysis. In Bullous impetigo, the changes you see are very localized, but as you know, the staph can present in a more generalized picture, as in staph scalded skin syndrome, where you may have an infant who presents with erythrodermia and skin peeling. Right, so this is a beautiful example, though, of Bullous impetigo. So just take it back, just take you out to look at it again. Remember, a nice blister, subcorneal location, lots of inflammation, bacteria, and evidence of acantholysis. All right, so that is slide number 1. Let's go ahead to slide number 2. So here you have another shape biopsy, and this is from the upper trunk. Let me just level it off here. And again, you see similarity right away. You see that there is a split again, and the split is in a subcorneal location. And let's go ahead and move in a little bit closer. There is an accompanying superficial lymphocytic infiltrate, but we're going to focus here in the subcorneal split. In this instance, the differential includes what you've just seen, but instead of being a toxin that is causing this split, you have instead an autoimmune reaction where you have antibodies against that same desmoglein 1, causing you to have acantholysis. And in this case, see, look here, you can see, and we'll go a little closer, that there are cells that are split and are at the top, right under the corneum. And then you could also see cells here that are just barely hanging on. You see it's hanging on by maybe 1 or 2 intracellular bridges. So these again are the desmosomes. And in this case, there are antibodies that are attacking the desmoglein in the desmosome. I call the desmogleins like glue, keeping the cells together. And this poor cell is clinging on. And so sometimes in this entity, which is pemphigus, in this case, Pemphigus foliaceous, we look for Klingon cells, or for instance, like here. Some people call them potato chips also. And you know how derms like to use food references. But this is an example of acantholysis in the subcorneal region and representing Pemphigus foliaceous. Now, there are others in the differential. There's other types of pemphigus which can be superficial like this. And again, the differential can include staph scalded skin. And so what could you do to help differentiate between these entities? Well, of course, you can do something like a direct immunofluorescence. And direct immunofluorescence will be able to highlight where those antibodies are going to. And what you're going to see is that those antibodies are going around each of the individual keratinocytes, and so that your immunofluorescence will look like a chicken wire pattern or a net-like pattern with IgG and sometimes C3. Now, just so you know, the desmoglein 1 we had mentioned already is in the upper part of the epidermis. So in direct immunofluorescence studies, typically it will be more highlighted in the upper epidermis, but sometimes it can involve all of the epidermis. So just be wary of that. Now this is P. foliaceous again, which clinically looks like very flaccid blisters. As a matter of fact, you may not even see blisters at all. This could look very much clinically like impetigo and just look like crusted areas. So this is something that a biopsy and immunofluorescence might help you in distinguishing in addition to your clinical. One other thing I like to mention is that the Pemphigus group can be associated with medications. So don't forget about the association with penicillamine. Don't forget about captopril or others, because you're going to want to look at the medication list when you make this diagnosis first. And also, this can be very tricky diagnosis on pathology, because since there's not a lot of inflammation here, you see just a little bit compared to, like, say, Bullous and impetigo, that the top sometimes floats away and you don't even pay attention to the top of the epidermis. You're too busy looking at all this going on down here, right? And so I tell my residents, be very careful in case the top is missing to still make your diagnosis. All right, so that was number 2, which is Pemphigus foliaceous, an autoimmune bullous condition. Let's move to slide number 3. We're going to turn it around and I'm going to focus on this piece here. So this piece is again showing you, I know it's a little cut up here, but don't focus here, focus up here. You see a split again. And of course, this split is representing acantholysis in this specimen. And let's go a little closer and look. Again, in this case, a vascular stratum corneum, but the split, instead of being in a subcorneal location, like we just looked at in the last 2 specimens, this is in a suprabasilar location, so right above the basal layer. And you can see it's quite extensive in terms of its broad, goes all the way across your specimen. Now let's look a little closer at this split. All right, so we're a little closer now, and you can see that again, the cells are coming apart, floating off into space, right here, and see these are in the, almost like in a little space here. But the basal keratinocytes are stuck down, and you all know because the desmosomes are just in between the keratinocytes, and in this case, we're looking at Pemphigus vulgaris. Antibodies are directed towards desmoglein 3, which tends to be in the lower part of the epidermis, but still in those desmosomes. And so they're going to come apart and you're going to see acantholysis. However, the basal keratinocytes are tacked down to the dermis by the hemidesmosome, which is not affected. And so here you'll see, and I'm just going across so you can see this beautiful acantholysis and looking for some great evidence of these basal keratinocytes here beautifully shown, that are tacked down but coming apart from each other, so they become very individual and they look like tombstones, right? So you all recognize tombstones in Pemphigus vulgaris. I want to show you another area, because in Pemphigus you can have involvement of the follicular epithelium as well. So let's see if I can show you a hair follicle. And in this case, again, we're very fortunate. Tom does such a great job of pulling great slides. You see here, this is a hair follicle, and here is the follicular epithelium. And this is the base of the follicular epithelium and nice split right above that. And let's go a little closer so you can see how the cells again are coming apart. See how they're coming loose and coming apart, and you have a wonderful split pretty much in the same suprabasal location, but represented in the hair follicle. Let's go ahead and look at this other hair follicle. I just want to emphasize this point. Here's a nice, beautiful hair follicle with the sebaceous gland, and you can see a split again. So here, you see these cells coming apart. So in Pemphigus entities, you can have hair involvement. All right. Now on direct immunofluorescence, since the target in Pemphigus vulgaris is desmoglein, but instead usually more desmoglein 3 than 1, on direct immunofluorescence, you will see that same net-like pattern or chicken wire pattern, but usually it's a little bit in the lower portion of the epidermis. Can involve at all levels, but typically a little bit more prominent in the lower levels. So that is a beautiful example of Pemphigus vulgaris. All right, let's go to slide number 4. And let's get this one squared up. You're in for a treat, because this is a rarer condition, and this is a rare form of Pemphigus vulgaris. This is Pemphigus vegetans. In this biopsy specimen, you can see that the surface is very papillomatous, right? Papillary projections are very papillomous on the surface. You can see that there's much more significant acanthosis and Reti downgrowth. So they're very elongated. As a matter of fact, this is epithelial hyperplasia when they extend down here. And even from this height, you can see, or magnification, you can see intraepidermal lacunae. See here and here at the bulbous ends of this downgrowth of Reti. So let's take a look at what is making up, or what is filling these lacunae. It definitely is inflammatory cells, and it's a nice combination of lymphocytes, neutrophils, and particularly, do you all see it? It's beautiful, eosinophils. Quite a bit, but there's eosinophils, neutrophils, and lymphocytes. So this is a great example. And the eosinophils aren't just here in the leukemia. Of course, you can see them right in the epidermis and in the surrounding dermis. Let me show you the other one. It's just too good. Here is another example of the intraepithelial leukemia that is showing you neutrophils and eosinophils. Again, when neutrophils are together, it's a little pus pocket, and this particular entity fits in with one of our other mnemonics or helpful memory devices. In this case, I'm not sure if you've heard about, but pH with pus. What that is pseudoepitheliomatous hyperplasia with pus. Now, typically that's infectious etiologies, but there are several that aren't. And we use the mnemonic or the saying, here come big green leafy vegetables, to remember the entities, or at least start to remember some of the entities that could cause pH with pus. So for the H, those are halogenodermas, but then there's chromomycosis, and there's bromomycosis, so those are fungal etiologies, granuloma inguinale, and then leafy, we remember leishmaniasis, and then finally vegetables, we think of vegetans, and so that fits, this pH with pus fits into that mnemonic. Now, even you remember that I told you that this is a variant of P. vulgaris, and usually if you look around, and in this case you can see it, there are areas where you can see that same pemphigus-like feature. Let me show you over here. In this kind of intraepithelial suprabasilar location, you can see acantholysis and the cells still coming apart. Do you see them? Coming apart and floating away. All right, because this is still an autoimmune condition with antibodies to the desmogleins. Now, this one clinically presents a little bit different from the Pemphigus vulgaris. This subtype usually has very vegetative, thickened lesions, and often will be found in the folds. It could be the head and neck, could be the folds, so it could be the axilla or the groin areas. And there's two types of Pemphigus vegetans. One is the halopotype and one is the Newman type. And the halopotype is usually more indolent and mild, and the Newman type tends to be more extensive and refractory. And for you Seinfeld fans, I always remember the Newman type as being the worst type, because Seinfeld always would say, you know, Newman, and he was the bad character. So that's how I remember that P. vegetans is the more refractory or severe type of P. vegetans. So anyway, this is a real treat. It's not very common, but it's a beautiful example. All right, let's move on to slide number 5. All right, and let's look at this particular piece here. I'm gonna turn it around again and focus on this one. This is a punch biopsy from the trunk, and you can see that there are maybe even skip areas. See, there's an area here and an area here that looks abnormal. And that really correlates with the clinical presentation of this entity, where you can have several papules. But the papules can be quite wide or plaque-like and confluent. But this is a nice example showing you that there's multiple clinical areas that you're going to see. From here already, you see there's a split. And so again, there is acantholysis, so the cells coming apart. But this has a few more different features. And so let's take a closer look, and I'm going to bring us closer. And you can see that the location of the split is suprabasilar, just like Pemphigus vulgaris that we were looking at recently, right? And here is an example. Here, here, here. See these cracks? This is the cells coming apart. But you do notice, right, that there are several other findings in this specimen. Overlying the suprabasilar acantholytic areas, you see a keratotic plug. You see that right here? Or a column of perikeratosis, very characteristic. And this is responsible for that red-brown crusty change that you'll see clinically in this condition. In addition, you see some of these keratinocytes are dyskeratotic. Now, dyskeratotic keratinocytes occur when the keratinocyte prematurely keratinizes. You know, keratinocytes just want to make keratin. That's kind of like they want to grow up, mature, and make keratin, and that's normal for them. But when they do it prematurely, with these, you know, and atypically, like this one, you call that a dyskeratotic keratinocyte. All right, but some of these dyskeratotic keratinocytes look very special. And I'm going to go down to this one because this is beautiful. All right, so look at this cell. This is a chorond. All right, and they see that the nucleus has become more shrunken or pycnotic. Okay, see it's smaller. There is a space or halo around this nucleus, and then you have these collapsed keratin filaments in a pink ring around it. That is a chorond, which is one of the forms of dyskeratotic keratinocytes. And this example is chock full of them. I mean, you can just look around and see that there are choronds being formed in many areas. You see here, 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 here. And this also demonstrates some grains, which are basically flattened basophilic cells, and they almost become into that column of perikeratosis up here. When you have suprabasilar acantholysis with these choronds and grains and this perikeratotic column, you're going to want to consider an entity called Dariers. And this is Dariers. You see how there's an area here, and you have maybe even a smaller area way over this side over here. And I just have to say, look at these beautiful choronds. Dariers is not caused by a toxin. It is not caused by autoantibodies like in the previous entities. It instead is a autosomally dominant inherited xenodermatosis. And many of you know this already, but it is a mutation of the ATP2A2 gene, which is basically a calcium pump that is essential for keratinocyte maturation and adhesion. Okay, and when you have a mutation, then loss of this adhesion, you'll get lesions like this. And clinically, you're going to see this in families. Many of you probably know families that have this. They have similar features. And these red-brown papules that I mentioned are often in a seborrheic dermatitis distribution, but can be in other areas as well. Other associated findings, remember, are like acrokeratosis ruciformis of Hoff, which are those verrucous, warty papules on the acral areas. And the nail changes, don't forget about the nail changes, those red and white streaks and the little nicks that you can get in the nails. But Darier's disease, again, another beautiful example. All right, let's go to number 6. Again, I gotta flip them around. And here you have a shaved biopsy. And even from here, even though we're gonna go closer up, you can see that there is some acanthosis to this specimen. See, it's a little bit of acanthosis. You do see little white areas, those spaces, and sometimes you might think that's spongiosis, or could this be acantholysis? Well, let's look a little closer and see. Well, when we get closer, you see that we are talking about acantholysis again. And you can see that their cells are coming apart. But in this case, instead of just being in a subcorneal area or a suprabasilar area, they're actually all over the place. This is the most extensive acantholysis you're going to see in an entity. And it's going to go from top to bottom, side to side in a way. It almost looks like, you know, and you've heard this term, I'm sure, a dilapidated brick wall, because it looks like a wall is coming crashing down and breaking up into the individual bricks. And in this case, the keratinocytes are coming apart, you see, all over top to bottom. Just like Darier's, this condition is an inherited genodermatosis, autosomal dominant, and this is Hailey-Hailey. All right, so Hailey-Hailey is usually found in areas such as the neck region or the axilla or the groin. And they look like the skin is just sometimes just tearing apart, or you have erosions. Unfortunately, because they're in folds, they sometimes get very macerated. And so sometimes you're going to see a lot of crusty material and neutrophils because they can get super infected. So it's not uncommon to see a little bit of acute inflammation in your Hailey-Hailey entities. Now, I think I mentioned to you that pemphigus entities, and actually now I'm going to tell you Darier's can have follicular involvement. And however, Hailey-Hailey does not. So Hailey-Hailey does not usually or typically involve the hair. And the residents, I always say, Hailey-Hailey has no hair, to remind us that these acantholytic changes just don't go down there. In your differential diagnosis of Hailey-Hailey is going to be, for instance, Darier's, but also an entity called Grover's. And I just want to mention, I don't have an example of Grover's today, but Grover's is often manifest by acantholysis, but it's also often small because Grover's clinically presents in the upper trunk of adults, and there's small erythematous macules or papules, very small and very, very, very itchy. But the pathologic changes of Grover's can oftentimes mimic Darier's, Pemphigus vulgaris, and Hailey-Hailey, but usually it's very small and tiny. Just so you know, it's going to be a clinical differential. Some of you may say, well, oh my goodness, this kind of reminds me of Pemphigus vulgaris. How am I going to differentiate Hailey-Hailey from Pemphigus? Sometimes Pemphigus can involve the flexures as well. And again, I will say to you, well, don't forget about your direct immunofluorescence, because a direct immunofluorescence will be positive, right, in things like Pemphigus, but in Hailey-Hailey, which is not an autoimmune condition with antibodies, it's going to be, your DIF is going to be negative, and so will the DIF for Darier's. All right, and so will the DIF for Grover's. It'll all be negative. So this is, again, a beautiful example of Hailey-Hailey. Let's go to number 7. I'm going to turn them around, and I think we'll go to this one here. Already in this one, it looks like a shaved biopsy of a discrete papule, and yes, it was. It looked like a somewhat umbilicated papule, or sometimes because it has this keratinous column and horn, again, it can look like a warty papule. So a lot of times you're going to biopsy this not knowing what this entity is, but thinking it's a wart or maybe even a squamous cell because you see keratin and a discrete papule. This entity's architecture is a little different from the previous ones. This one looks endophytic. You see that? It's endophytic going inside. Although this entity can be exo and endophytic, is often endophytic. So let's look a little bit higher magnification and see. You can see this entity was taken from a head and neck area, which is where it most commonly is found. And down here you see, again, yes, cracks. So cracks representing acantholysis. Let's go down a little further. This entity has villous processes, like finger-like projections into the center area. So it has a little bit more villi than you had seen in any of the previous acantholytic conditions. And here you can see that the location is, again, suprabasilar, and the cells are coming apart. Let me just show you. Beautiful acantholytic process. The cells coming apart. And then here you can see a column of perikeratosis and corons and grains again. See, let me just see if I can find some for you. Here are some beautiful grains. You know, the other examples show beautiful corons and just some grains, you know, and this one's just showing you some of those great basophilic flattened keratinocytes and showing you some beautiful grains. And there's some evidence of corons too, where you have that pycnotic nucleus and that halo around it, and also some dyskeratotic keratinocytes. So I think this is a beautiful example of a warty dyskeratoma. And if you want to distinguish this from something like Darier's, because it also has corons and grains and superbasal acantholysis, you need not go farther than look at the clinical picture, because again, warty dyskeratoma tends to be a single lesion instead of Darier's, which tends to involve multiple papules, again, seborrheic distribution, head and neck, and elsewhere. So this is a warty dyskeratoma, or my residents and I say warty D baby to remember this entity, but it is a beautiful example. So that was number 7, and we're going to go ahead and move on to number 8. So number 8 is a beautiful shave biopsy of a papule. Now I like to remind our residents that acantholysis, in terms of what we've seen so far, often reminds us of, you know, the infectious that's called the skin, or autoimmune bullous, you know, or now I mentioned Darier's, all these entities. But I don't want you to forget that acantholysis can occur in this entity, which is a squamous cell carcinoma. So acantholysis can occur in actinic keratosis and squamous cell carcinomas. But in this case, because the keratinocytes are forming abnormally, or they have mutated, and so they're not making the proper connections between cells. In this entity, you can see overlying serum crust and keratosis. So it's a keratinized papule. And you see pink proliferation, and with downgrowth, a very infiltrative pattern. In this case, a pretty well differentiated squamous cell with pink keratinizing cells going down deep into the dermis. And let's go a little closer. Up here, here it happens to be some serum crust and some columns of perikeratosis, which again retained nuclei in the overlying keratin. And maybe you can see it here. I'll just zoom in to remind you, this is overlying perikeratosis with retention of the nuclei, loss of the granular layer, and underneath a squamous proliferation, almost glassy, very pink, very well differentiated. Over here, you can see that the cells are definitely coming apart in the acantholytic process. See here, the cells again coming apart and floating away. But again, this is by mutation. Now, how do you identify this as a squamous cell compared to those other entities? Well, first of all, you have the architecture of these epithelial downgrowths in an invasive pattern. You see that it's keratinizing. You see that there are keratin pearls. Remember, keratinocytes just want to make keratin, and they'll make all sorts of keratin anywhere, and you can get pearls. You may get dyskeratotic keratinocytes. But then you got to look close and see the nuclear pleomorphism, which are the nuclei of these cells are different in size and shape from each other. You also see that it's very disorganized. Let me just show you some of these. Here, see dyskeratotic keratinocytes. Dyskeratotic keratinocytes, disorganized keratinocytes, some keratinocytes larger than other keratinocytes. I mean, look at that one. Look at these here, very large, atypical looking keratinocytes. And then hopefully evidence of mitotic activity. So when you see an infiltrative pattern, mitotic activity, and maybe even atypical mitosis, you might want to think of squamous cell carcinoma. I'm going to go to another section. Let's look at this one. See here, epithelial downgrowth, very pink, very keratinizing. Dyskeratotic keratinocytes, mitotic activity, atypical, Oh, here, a beautiful one. See these concentric keratin layers of a squamous pearl. And we'll just kind of look around and see. Does everybody see how atypical this looks? Oh, look at this one. That is an atypical mitotic activity. As a matter of fact, that kind of looks like the logo for Under Armour. I don't know if you see that, but that is very unusual mitotic activity. So that helps you know that we're dealing with a malignancy. To see atypical mitosis deep in the dermis. Again, look at these cells. They look very, very bad, very different from each other. Nice squamous pearl. So this is squamous cell carcinoma, showing you acantholysis as part of its process, or acantholytic squamous cell. Okay, let's go to slide number 9. This is another blister for comparison, and I'm going to move it like this, and let's go ahead and focus on this middle slide. This is now a punch biopsy taken from the trunk. Everybody sees the blister here and cells floating. Let's take a closer look. This one is a blister in an intraepidermal location with a accompanying quite significant or brisk inflammatory reaction. This process is a little different from the ones I've shown you, and I'm going to bring us a little bit higher magnification so you can see what is happening in here in this blister. Now, a lot of the changes are occurring in the suprabasilar region, but the cells affected can affect all areas of the epidermis. The very first change in this process, oh my goodness, this is gorgeous, is the peripheral margination of chromatin. So let me go and focus on some of these. The nucleus, because of viral replication occurring in the nucleus of these cells, and is becoming very still gray. And the chromatin is going to the edge of the cells, kind of being pushed out to the edges, and it looks like a purple eggshell. Does everybody see the chromatin margination? All right, in all of these cells, chromatin margination. This is one of the 3 M's of this entity. This is a herpes virus infection. I'm sure you all got that. And margination is one of the M's. What is another M? There's 3 M's. There's margination, there's multinucleation, and there's molding. And you see all of them so well represented here with margination, multinucleation. See how many nuclei are in this one huge cell. And then you have molding. You see how the nuclei fit together, molding together, kind of bending each other. I want to show you that in herpes virus infections, that this chromatin margination can be found at all levels, you see? And so can the multinucleation and molding. And the process that's occurring here is several-fold. For one, with the virus replicating in these cells, they balloon out, right? They balloon and they get really big, and then they lose their connections and come off. So this is an example of ballooning degeneration with secondary acantholysis. And then also, this is a great example of reticular degeneration, where the cells break open, and then you get fine cytoplasmic strands. I want to show you that. Like, for instance, here, see all these little strands? It looks like broken spider webs. Okay, that is reticular generation. And herpes virus infections have ballooning, reticular generation, and secondary acantholysis. But the viral changes help you pinpoint, that this is not autoimmune, not cancer. This is viral. Now, herpes viral infections like this look very similar, whether you're talking about herpes simplex or whether you're talking about varicella zoster virus or shingles. As a matter of fact, you can't always look at the pathology to differentiate between HSV and VZV. Now, VZV sometimes can have so much inflammation in the perivascular location, be more hemorrhagic, but you can't always rely on that. So you may want to clinically, if you don't have a good picture of whether it looks like HSV or VZV, to do either viral culture or PCR testing. And you could also do immunostaining directly on your formalin-fixed tissue to help you differentiate between the various viral elements. So this is just beautiful. Kind of looks like what your Zank would look like, right? All right. And herpes can involve the hair structures. So we can also look down the hairs to see if there's viral changes in the follicular epithelium. Let's go to slide number 10. All right, so I have to flip them over again. Flip them over, there we go. All right, so I thought we'd continue with the blistering theme for the last 3 slides. And this one from afar looks like a shaved biopsy, and this is again taken from the trunk. And from here, it looks more normal than the ones we've been looking at. You know, basket weave, stratum corneum, somewhat normal, right? Epidermis. But you start to notice that there is a superficial infiltrate. Some of it's perivascular, but there's something happening in the dermal papilla here, here, here. So let's take a closer look at those areas. Let's go closer. All right, and even closer. Ah, beautiful. In this case, you see it's not just lymphocytes that are in the dermal infiltrate, but there are also neutrophils. Do you see the neutrophils in the dermal papillae? It's stuffing the dermal papillae, and there seems to be almost a break here between the dermal papillae and the epidermis, and you can clinically in this condition have small little vesicles or bubbles. Let's go to this other location here. You can see here again, in the dermal papilla, that you have neutrophils stuffing it. And the neutrophils at the tips of the dermal papillae are representative of a condition called dermatitis herpetiformis. When you have neutrophils in the subepidermal position, you may think of several entities. Dermatitis herpetiformis is just one of them. Other entities can include linear IgA, right? It could also include EBA, or epidermolysis bullosa acquisita, or bullous lupus, and even forms of bullous pemphigoid. Let's look at another entity. Another slide. I think this one also was beautiful. So here you have the shaved biopsy, and we're gonna look closely at the dermal papilla. And look, look at this. That is beautiful. So you see the neutrophils stuffing the dermal papilla, and you see this break. And if given the opportunity, that potentially can make a tiny little vesicle. All right, now how would you distinguish this from other entities in the differential that I gave you? Well, the easiest way is to do, again, direct immunofluorescence, and you may find that there's IgA granular deposits in the dermal papillae that coincide with these neutrophilic microabscesses here. Now, dermatitis herpetiformis is a very, very itchy condition, and you will often see clusters of small vesicles, or because they're kind of fragile, or maybe because they're so itchy that people scratch them open, you'll find just superficial erosions. And they're typically located on extensor surfaces of the body, like the elbows and the knees, and sometimes the buttocks or the scalp. And you all should remember that is associated with a gluten enteropathy or gluten sensitivity, and it can be associated with gastric lymphoma. So don't forget about those clinical correlations. This is something that you should know. Responds very well to dapsone because of the anti-neutrophilic activity. Okay, we're almost there. Just a couple more slides. Number 11. Let's turn this one around. This is just another great example. This is the way I like y'all to biopsy vesicular lesions. If you can, if they're small enough, just get the whole thing with some of the edge. You know, always get the edge into the blister. Don't just get the center of the blister. If you just get the center of the blister and it's been there for any period of time, it's going to be all dead in here, and you're not going to be able to use your pathology to help you with your diagnosis. You want a fairly fresh blister, and you really want to get, if you can, the blister and the edge. So great job, whoever biopsied this blister. All right. Now, look at the location of this split. This split here is in a subepidermal location, just like the last entity, but more pronounced, right? More pronounced. Also, I want to show you that the split is very smooth. A smooth underbelly like this is very typical of autoimmune conditions. And let me show you here. See how smooth that split is. The overlying epidermis is quite normal appearing, right? See how and I'll go a little closer just so you can see. The problem in this entity are antibodies against what's holding that epidermis down. So in this case, antibodies are hitting the hemidesmosome, and in this case, Bullous pemphigoid 1 and 2. And when it does so, the epidermis is easily comes off. Now, this blister top has the full epidermis. So in entities like pemphigus, where you have a very thin top layer to the bulla, they're going to be very flaccid and fragile. But because the split is in the subepidermal location and your epidermis is intact, these can get quite large blisters, and they're very tense. So they don't break open as easily. Let's see, normal and a smooth split. When you see a subepidermal split, you do want to look at the infiltrate, and this infiltrate is a little different. You can already see it here. Sorry, let's go back and look. Infiltrate is full of lymphocytes, neutrophils, and eosinophils. And when you have a subepidermal split with eosinophils as one of the prominent inflammatory cells, then it does bring to mind a different differential than the last entity, DH. Instead, the differential includes herpes gestationis or pemphigoid gestationis, drug reactions, and bug reactions, right? So let me look at the corner, because I always like to look first at the location of the split, the type inflammatory cell, and then I like to go look at the edge. And here on the edge, you can see that the split is still smooth. And I like to go and look around here. You see that those eosinophils are not just in the blister, but they're also found in the surrounding skin. And there may even be eosinophils in the epidermis with spongiosis. As you know, Bullous pemphigoid can manifest with eosinophilic spongiosis and have urticarial plaques amid the areas of blister, or can even precede the clinical finding of blisters. And one nice little clue is that the eosinophils are not just here in the epidermis, in the spongiosis, or here in the dermis lying free in the infiltrate, but they're often lining up at the junction. I want to show you that because that's a nice clue that we're dealing with Bullous pemphigoid. You see the eosinophil here lining up along the junction and here as well. I think that's beautiful. Look, here's more. Eosinophils here. Here, see how they're lining up at the junction? Well, given time, they may be able to split this epidermis in these other locations. That's why I just love to have the perilesional area examined as well. Gives you all sorts of clues. Let's go to the other side and see if we see similar findings over here. So here you have intact, epidermis that's tacked down, and then you can start to see how it's coming apart. And you can see subepidermal split, lymphocytes, neutrophils, eosinophils. Look over here to the left, and you see spongiosis. See how there's a little bit of lightening in between the keratinocytes. Eosinophils or eosinophilic, spongiosis. And then again, let's just see, yes, here, look at that. Eosinophils in the dermis, and also tagging the very bottom of the epidermis at the dermal-epidermal junction. So I just think this is another beautiful example, and this is bullous pemphigoid. If you were to do direct immunofluorescence to help differentiate between the differential I gave you, of course, in bullous pemphigoid, you're going to have antibodies going to BP1 and 2, as I mentioned, and so you're going to see a linear deposition of immunoreactants, IgG and C3. If you were to do a salt split skin, you would see the immunoreactants lining up at the undersurface or the roof of the blister. All right, now we're going to our very last slide. This is slide number 12. And we're ending with a slide showing you a very serious condition. The split is found in the subepidermal region, just like bullous pemphigoid, but there are significant differences. Let's go ahead and look down. First of all, you can see that it's really not as inflammatory as bullous pemphigoid. It's more what we say pulsy inflammatory. The epidermis undersurface is not that smooth, nice autoimmune look to it. It's more ragged and disrupted here. The overlying stratum corneum is basket weave, showing you that this is an acute process or a process that occurs very recent or very quickly. And then, unfortunately, you see that the keratinocytes here are not healthy at all. You may see individual cell necrosis, or like in this example, full thickness epidermal necrosis. This is cell death. And I'm just going to turn it like that so you can just really appreciate that the whole epidermis has died, and has died very quickly. The bottom, very paucicellular. And you all must recognize that this is toxic epidermal necrolysis, or TEN. This is trouble to the patient, usually elderly, usually associated with a medication. So you really need to look at their medication history to try and figure out what caused this horrible drug eruption. As you all know, mucous membrane involvement, significant extensive blistering and skin sloughing, positive Nikolsky sign. These cells are dead. And when you recognize this, you must quickly make sure that that patient is in the right place, that they need to have high level, skin care. So usually in a unit situation. So this is TEN. I'm sorry, it's the very bad drug eruption, and we're ending on all this cell death. That this is a very important entity to recognize, TEN. So we end our slide review today, our session today, with these 12 entities with a lot of bubbles and blistering. I hope you enjoyed them, and I hope you're enjoying your happy hour and have maybe something bubbly to go with our talk. So thank you so much again for letting me speak to you again.
Thanks so much, Sandra. Really appreciate it. We do have a couple of questions here that I can address. I'm going to go ahead and share my screen here. The first question, let me go ahead and get this up, pertained to, and let me get my chat here, pertained to question number 5, and it was, can number 5 Darier's also be Grover's disease? And I would say the answer to that is an emphatic yes. Generally on a board or certification exam, no one's going to ask you to distinguish between Hailey-Hailey and Grover's, or Pemphigus and Grover's, or Darier's and Grover's. And that's because, as you remember, Grover's can present in the skin with a multiplicity of histologic findings. And even though the lesions are small, if the biopsy is small, the acantholysis or spongiosis can extend to both edges. And so you really need to be able to correlate with the clinical. If you see a biopsy like this with suprabasal acantholysis, and as is the case here, and Dr. Osswald pointed out, there is pretty obvious dyskeratosis in the form of corons or grains, then you can distinguish that and the entities that are characterized by that from, say, Hailey-Hailey and from Pemphigus, because neither Hailey-Hailey or Pemphigus have as much dyskeratosis as, say, Darier's disease or a Warty dyskeratoma. So hopefully that helps. If you need any more clarification, please feel free to email us at education@sagesdx.com, or you can email me directly, tdavis@sagesdx.com. And then we had a question about number 12. I'm going to bring that slide up here too. Could this also be SGS or EM? I think the reason that we would favor TEN here is because of the full thickness, extensive epidermal necrosis in light of a very sparse inflammatory infiltrate. Yes, I do think the disorders run along a continuum. In most cases of EM, depending upon where the biopsy is obtained, you'll see scattered necrotic keratinocytes, a basket we've quantified layer, and typically not full thickness atypia. Can you sometimes see it if you biopsy the necrotic center of a lesion of EM? Yeah, you can. But when you see full thickness epidermal necrosis and a cell pore subepidermal split with sparse infiltrate, generally TEN is your preferred diagnosis. SGS and EM run along a continuum, and the only way you can discriminate those, of course, is with clinical data, because with SGS, of course, you get mucosal involvement. So anyway, hope that helps. If anybody has any additional questions, please feel free to contact us. Don't forget to register for the upcoming board exam, review the Dermpath core exam, and hope everybody has a great evening. Thanks for tuning in, and a big thanks and shout out again to Dr. Osswald for an excellent presentation. Thank you.